My name is Austin Fox. I'm a glaucoma specialist and a cataract surgeon here at Gavin Herbert Eye Institute. And it's an absolute pleasure to be here with you. Thanks for joining us as we talk about glaucoma. It's a subject I'm really passionate about because it's a complex condition which leads to blindness. In fact, it's the leading cause of blindness in the world, but it's a treatable condition. So we'll talk about the latest treatment updates in glaucoma management. And then, like Dana mentioned, just feel free to place questions in the chat, and I'll try to answer throughout, or we'll have the question and answer, the Q&A at the end of the talk as well. And so actually, just a little bit about myself. So I just kind of put together this graphic previously and want to include it here. I'm originally from Alabama. That's where I went to medical school. And in medical school, I actually spent 2 years at the National Eye Institute in Bethesda, Maryland. And it was there I became interested in ophthalmology. And then after the National Eye Institutes, I went back, finished med school, and did my residency in the University of Iowa. And then ended up coming out here to California at UC Irvine, where I joined about 4 years ago. And so I've been here about the last 4 years, and I really enjoyed it. And so what we'll talk about tonight is we'll talk about glaucoma and what is glaucoma. We'll review the background of glaucoma and the basic anatomy, really to answer or the question, what is glaucoma? We'll review the treatments after that, and then talk about some of the newer treatments that come out as well. Well, so why is glaucoma important? Well, it's the second leading cause of blindness, irreversible blindness in the US, following macular degeneration, and it's in the world, it's the leading cause of irreversible blindness. And as you can see here, the cases are only expected to and projected to increase in the United States. And so what is glaucoma? Well, glaucoma is thinning of the optic nerve. The optic nerve comes into the back of the eye, which you can see here, and it serves as this information highway between the eyeball and the brain. So the eye focuses light onto a specialized tissue in the back of the eye called the retina. And it's more like the specialized lining of the eye. And then some cells in the retina send that signal to the brain through the optic nerve. And it's really these cells sending the light signal to the brain where we experience vision. And so the optic nerve, what it is, it's a bundle of over 1 million nerve fibers responsible for transmitting this nerve signal to the brain. And on the right, you can see that this is an image of the back of the eye, the optic nerve, which the ophthalmologist sees when we look to the back of the eye. And it's really the front surface of this optic nerve, which we can look at, and we can determine, whether you're a glaucoma suspect, whether you have glaucoma, whether you have thinning of the optic nerve. And so you can kind of think of this as like a donut. It's a thick rim of dough here. And then this is the healthy nerve on the left. And then if there's thinning of the optic nerve or a thin amount of nerve tissue, then that's where you get this optic nerve cupping or glaucomatous cupping. And so this is glaucoma. What is it? So what does this mean clinically? Well, clinically, what you're going to see is you're going to get tunnel vision. So really the vision loss starts peripherally, and then it may extend centrally later in the disease. So one issue is that glaucoma does not have obvious signs or symptoms in early or moderate stages. Because of this, glaucoma has really gotten this nickname, a theft in the night. And it may only be detected by eye examination in these earlier stages. So by getting a basic eye exam, including, you can see here, vision with the glasses, intraocular pressure. This is us taking the pressure of an eyeball. And then just a dilated eye exam, we can look back to the optic nerve and really screen and evaluate for glaucoma. So screening is really important. This is really the first take-home point here of this talk is, screening is important to identify and prevent permanent vision loss from glaucoma. And so, kind of just a fact that I always think of is that in the United States and other developed countries, about up to half of individuals with glaucoma are actually unaware that they are affected. And so, fortunately, if we identify and screen these patients, we're able to slow down or halt the progression of glaucoma with treatment. And if caught early, we can preserve vision and prevent vision loss. So based on risk factors and the dilated eye exam, we may obtain a test, especially essentially to identify glaucoma. And this is more of a structural test that measures the optic nerve. You can see the optic nerve here on the right eye and the left eye. And you can see that there's a little bit of red color here that indicates that there is some thinning of the optic nerve. And this is compared to age-matched controls. And so this really allows us to identify and quantify the degree of thinning of the optic nerve. And then we use a visual field test as more of a functional test. And because remember, like glaucoma usually presents with peripheral vision loss, we can really detect any visual field changes with these different lights that we shine and we ask you to identify. And so putting this together, you see that this is a visual field up here that's really healthy. It's a full visual field. And then this is actually the back of your eye, the optic nerve. And I overlay these blue cartoon cells here to indicate the optic nerve fibers to depict the optic nerve cells as they combine and form the optic nerve here. And there's actually about 1 million of these, but I just show a few for just to kind of demonstrate this point. And so as you lose these blue fibers, you slowly get visual field loss. And so this is a classic pattern of glaucoma field loss. And then at more advanced forms of the disease, you can get successive tunnel vision, all right, until you have advanced glaucoma. And this is what we're trying to prevent. And so, over years, glaucoma may result in this progressive loss of optic nerve cells, this gradual cupping, and then, the peripheral vision loss. Which again, you can see that here that this is kind of just to show you clinically what we're seeing out. A normal healthy eye will see the full picture, but then you get a tunnel vision and advanced glaucoma. So how do we treat glaucoma? Well, the treatment is to lower the intraocular pressure. And this is not blood pressure, but it's eye pressure. It's the pressure actually inside the eye. And so the intraocular pressure is the only modifiable risk factor to slow down progression of glaucoma. So really, this is a plumbing issue. You see this, there's a faucet making fluid, and then there's a draining fluid right here as well. And just kind of look a little bit closer here, you can see that there's this tissue here on the left side of the screen. It's called the ciliary body. That's more like the faucet. And then, that releases fluid, and the fluid goes around to the drain, which is here, which, we call Schlimm's canal, or the trabecular meshwork. And so the pressure rises if the drain does not work, and high pressure damages the optic nerve, and that's what results in glaucoma. So the goal of the glaucoma treatment and the medications is to lower the pressure so that we can prevent further thinning of the optic nerve. And so we do that a few ways. We do that with laser, which you can see here on the far left. And what we see here is you can see that there's a pigmented tissue here. That's called the trabecular meshwork. You can kind of think of that as like the filter of the eye. And you can see the laser being aimed towards that pigmented tissue. We'll talk about it a little bit here in the next slide, but then we can use drops, which turn down the faucet, and then ultimately, if we need to, we can do surgery, which we do a lot of surgery to stabilize pressure and glaucoma. Here, so this is the laser. It's called selective laser trabeculoplasty, and traditionally drops have actually been used before laser, but multiple studies within the last 5 years have been performed, and they suggest that SLT should be considered as an initial treatment. And so it's a very gentle laser, which is used to stimulate these drain cells, these filter cells, the trabeculocytes. And so this drain, you can see, is actually in a circumferential pattern here, and it's actually a 360-degree drain in the front of the eye. And so this works to increase the outflow of fluid through that drain to lower the intraocular pressure in patients with glaucoma. And so this is actually just another photo, a couple other photos showing this procedure being done. It's about a 5-minute procedure. It's a painless procedure, which is performed in clinic. And you can see here, this lens is used to aim the laser at the front part of the eye to the trabecular meshwork. And, I would say that probably the it's you don't feel anything, but probably the biggest thing with this laser is that it works about 75% of the time. And when it works, it works. It's about equivalent to about a drop. And then this far right photo, you can see this is exactly what we see in clinic and when we perform the laser at the slit lamp. And so this is actually just one of the trials that I just wanted to mention because it was a landmark trial here in our glaucoma community, published in 2019. And I think based on this trial, stuff published 5 years ago, if I had glaucoma and needed to lower the intraocular pressure, I would first consider the selective laser trabeculoplasty for myself. Now, I must just distinguish here just a little bit. The caveat here is that you have to have an open view to the drain. So you have to have open angle glaucoma. You can't do this procedure if you have narrow or closed angle glaucoma. And so that's a big distinction here. But this study was called the Laser in Glaucoma and Ocular Hypertension, the LIGHT trial. And it showed that SLTN drops have similar IOP lowering effect. However, the SLT group was likely to be off drops at 36 months, so 3 years. And the drops group was more likely to need surgery. And then a follow-up study was done after this to suggest that the SLT group outperforms the drop group and as far as the rate of visual field loss goes. And so it stabilizes the actual condition better. And so based on this, the conclusion is that SLT should be routinely offered as a primary first-line treatment. And so this is actually just early in the course of disease, but it's a good option, initial option. But really, eye drops remain the backbone of our treatment. And while we have a few newer drops and drops in the pipeline, most of the drops we have been used for decades. And the purpose is to decrease the production of aqueous fluid at the faucet, which I again included here, or to increase the outflow at the drain. And so we have about 15 different drops from 6 different medication classes. And some drops may not work well for everyone, or they may not be as well tolerated by everyone. And so you have to find the right mix of drops that work for you. And you may notice here that the caps are different colors. And this is really the easiest way to identify the drop class. And so I show that right here, each class with the different medication name below has a different color. And so you can see that I divided this right here, that these drops on the left increase outflow and the drops on the right decrease inflow to achieve a lower IOP. And so we'll go through a few of these drops right here actually, and some of the newer drops as well, and just take it one class at a time. This is the prostaglandin analogs. They are more of an aqua cap, and they're really the workhorse for us in glaucoma. They increase outflow, and they're the strongest drop we have as far as lowering the pressure. They lower the pressure about 30% with once nightly dosing. There are about 4 prostaglandin analogs, which you can see here, and that we currently have available for clinical use. And you may be familiar with some of these. I'll mention that the Iuzia, that's actually a preservative-free latanoprost. The Travatan Z, that has a more tolerable preservative for travoprost. And then a truly preservative-free option is tafloprost or Zioptin. Generally, I start with latanoprost, though, Zalatan, because it's inexpensive and it's generally well tolerated. As a whole class, they're well tolerated and they're highly effective. Yeah, but let's discuss some side effects though, because not everybody tolerates these drops. So one of the things you'll hear about or read about is iris color changes. It's observed in about a third of patients after 5 years, and then you can get some skin hyperpigmentation around the eye that can occur. But this is reversible, and so I'll show you this right here. This is the color change of the iris. It can you can get essentially darker pigmentation of the iris. And then right here you can see there's actually another side effect is eyelash growth, And then you can get orbital fat atrophy, which you can see here, where there's the fat pads around the eye just they atrophy or they decrease in size. Vyzulta is another prostaglandin analog, which has a nitric oxide donating moiety, and it allows the drug to be a little bit more effective with an additional 1.2 points of IOP lowering effect over latanoprost. I would say the downside of Vyzulta is it can be a little bit more expensive. Okay, the next group is the beta blockers. Timolol is another staple that works by decreasing aqueous production. It's dosed once daily in the morning. There are 4 beta blockers you can see here, currently available for clinical use. And it's generally well tolerated. The patients can develop allergy, but it's well tolerated locally around the eye. There are some systemic side effects which can limit its use. And you see here, primarily shortness of breath or wheezing in patients with COPD or asthma. So you want to be careful when you're prescribing for patients who have these conditions, or try to avoid it altogether. Next, we have brimonidine. It lowers the pressure about 20 to 30% through decreasing production, aqueous production. And it also has a little bit of a component that increases outflow. It's dosed 2 to 3 times daily. And we're primarily talking about brimonidine. Generally, when we do not use the aproclonidine, the second one right here, long term, because it can cause a lot of irritation. And generally, brimonidine, it's mostly tolerated. However, allergy can occur in about 20% of patients. And here's a picture of a patient with conjunctivitis and just this erythema around the eye. And so really it's important not to get the drop on the skin. But you can also get this conjunctivitis where there's a little bit of this follicular pattern down here that just causes a little bit of irritation, a little bit of scratchiness. And so in these cases, rather than continuing the brimonidine, you can see that this maybe the SLT laser could be beneficial where we don't have to take a drop. The next class is the carbonic anhydrase inhibitors. It lowers the pressure about 15% through twice daily dosing. We have 2, dorzolamide and brinzolamide. They may sting a little bit, but really the bigger issue here is that it can be a little harsh on the cornea and cause a little bit of corneal toxicity. So that we usually are cautious about use in patients who are at higher risk for corneal decompensation, such as patients who've had corneal transplant. Okay, we're almost wrapping up the drops here. I'll talk about a couple more. This is the Rho kinase inhibitors, also known as Rhopressa or Notarsadil. It works by multiple mechanisms, so it may be good for patients with glaucoma who already have a low pressure or who have normal tension glaucoma, but it's also dosed once nightly. With the Rhopressa, hyperemia is the most commonly reported side effect, and otherwise it's pretty well tolerated. There is a finding that is not visually significant, but you can get this little world verticillata pattern is what we call it on the cornea, which is classically associated with Rhopressa, but again, not visually significant. Okay, lastly, this is actually a newer drop, which it's actually not been released in the United States yet, but it should be released in the next few months. It's Amlanti or amidinipeg. It was first introduced in Japan and has been used quite widely around the world since 2018. And so, it's similar to a prostaglandin analog dosed once nightly. But unlike other prostaglandin analogs, Amlanti works on a different receptor, which has not been associated with the fat atrophy around the eye, and so, or the sunken eyes. And so, we're excited about this drop because it gives us one extra option for patients with, maximum medical therapy. So, we prefer using combination drops. So we talked about each individual drop, but we do have combination drops, which we prefer over separate components primarily to facilitate adherence, reduce exposure to preservatives, and possibly reduce costs for patients. So these are the combination medications that are available and commonly used. We also have a number of preservative-free or BAK, benzalkonium chloride-free options for these patients who cannot tolerate the preservative, which you can see here. And so we're going to put all this together, and this is kind of typically the treatment algorithm I go by. And after we determine that a patient needs to be on treatment and we set a target pressure, we might consider the laser, the SLT. But if we need more of a low IOP lowering effect, I'm going to start with the latanoprost as a single agent. And for me, that's most often going to be the Zalatan, the generic latanoprost. And then, if there's a decent but inadequate effect, I'm going to add a second agent. That's going to be timolol dosed once in the morning. And in this process, I'm considering multiple contraindications and whether they're the medication's the right fit for the patient. And then, if we need more, I'm going to add berzolamide, and that's in the form of a combination drop called Cosopt. And then if we need an additional drop, we're going to add brimonidine. And, up to this point, we might be thinking about cost because we're on multiple medications, and these medications have to be refilled every month. All these medications that I've talked about so far in this algorithm, they're generic, and so I think that brand name medications may be helpful if the medication is not tolerated, but rarely would I switch to a brand name within a class if it's not effective. But it might be helpful to get you to a preservative-free option if you had an irritation from one drop. And so also, I must mention, once we get down here to the bottom, I'm asking, can we tolerate the medications? Can we afford the medication load? And then this is a lot of drops throughout the day. Each additional drop, you have to take a few extra minutes to put them in, and it takes a lot of time. And, so once I put a patient on 3 drops, I'm usually introducing the idea of surgery. And then with another, additional medication in the form of the combination of Rocklatan, I might add this drop if we need more pressure lowering effect. I just want to put a plug in for NanoDropper. No financial interest in this device, but it's a relatively newer device that's been really helpful for improving drug tolerance and compliance. It's an adapter that you put on to the bottle, which you can see here, the drop volume is much smaller here out of the NanoDropper versus the regular drop top that comes with the normal drop. But it decreases the drop volume by about 60%. And with that extends the life of the bottle, decreases the size, the side effects, reduces cost, and it's also easier to squeeze the bottle. So, it's can be easier to administer. And so, I mentioned the idea of surgery on the last slide, and, I think that, drops will always be a part of glaucoma management, but we're moving in the direction of, reducing our dependence on drops. And so right here, essentially what this is this just shows sustained release medications. What if we can decrease the need to take drops? There's multiple ways that we can, add a medication so that you don't have to think about it. You don't have to put the drop in every day. You don't have the side effects on the surface of the eye. And so there's punctal plugs right here. You can see there's different devices you can put into the eye here at the upper left-hand corner. And here, there's this little pellet being put into the eye. There's also different spaces around the eye where you could place the medications. Currently in trials, there's a lens that you can place inside the eye at the time of cataract surgery, which can hold a medication with it, which can elute and lower the pressure over time. This is there's really actually only 2 devices right now that are approved by the FDA, but this is pretty exciting because it'll allow us to better treat glaucoma patients as we move forward in the direction of eliminating adherence issues and really barriers to treatment. So I mentioned there's a couple of intracameral or implants that you put in the eye. Right here, you may have heard of Durista. It's the first that was approved by the FDA, and it's a implant that's a sustained release medications. It's actually bimatoprost, so it's a prostaglandin analog. And, it's placed in clinic, designed to release the bimatoprost over a 90-day period. And, it's a very small little pellet that you can see right here. The thing is that it's kind of floating around the eye. And, one of the issues here is that it's can be very close to the cornea. And so it can be a little harsh on the corneal cells. And so for that reason, the FDA actually only approved it for one-time use, which actually limits its relevance a little bit. But there is hope that the safety profile will be improved for multiple injections as this medication or this device is reiterated and improved with time. More recently, Glaukos released the iDose. It's a travoprost implant. It's a reservoir, which you can see here. It's actually has an anchor on it, which is anchored into the wall of the eye or the sclera. This does require placement in the operating room. But as far as effectiveness, they quoted 81% of iDose patients were completely drop-free of topical medications at 1 year. And so that's pretty good. Again, this is FDA approved for one-time use, but it's limits its relevance, but it's a major breakthrough in this paradigm shift to reduce the dependence on drops. On the same note, you might have heard the name MIGS. It's micro or minimally invasive glaucoma surgery. And these procedures it's a newer area of glaucoma management, which has really taken off over the last decade. These procedures are performed in the operating room. So we're moving from the medications to procedures here. And you think about surgery, may think, oh man, this is really scary. It's something we take very seriously. And, it's something that, surgery does have real risk, but, the good thing about the minimally invasive glaucoma surgery is they have an extremely high safety profile. They require shorter time in the operating room, and it allows for a pretty rapid recovery. And so in general, in MIGS, we're typically cleaning out or augmenting your own drain. And remember, the drain is located 360 degrees, which you can kind of see that depicted partly here in both of these pictures. And it's around the front of the eye. And so we're just working in the front of the eye here. And if you want to keep that plumbing analogy, the MIGS procedure typically opens up or it cleans out the drain that you have, sort of like a roto-rooter or like a snake for your sink drain. And you can see that here there are multiple MIGS procedures, and there's implants here on the left. And then here, procedures that do not require implants are here on the right. And so what we're doing is we're really just cleaning out your drain. Here are a few more MIGS procedures just to show you a closer look at the multiple options we have when it comes to MIGS. This is the eye stent here, which is placed in the trabecular meshwork. This is the Hydra stent, which is also placed just behind the trabecular meshwork, actually. It helps keep open the drain. This is actually kind of like the roto-rooter, where this catheter goes around the eye for 360 degrees. It's the Omni device. And then right here, this is actually the Kahoot dual blade. So this actually allows us to remove the filter of the eye that's clogged up. So I just actually have a video here of this procedure. And so if you're queasy with eyes or surgical videos, you can close your eyes. But I'll just show this and kind of show what we're seeing in the operating room. So here you have a catheter, it has a blinking light there. It's been inserted into the canal. And we're going to use this very fine microforceps to essentially direct this catheter around the eye. And you can see the blinking light coming around the eye. It might be a little choppy here. It's a little choppy on my end right now, but let's see here. So I will also mention, so we're threading it around the eye 360 degrees. This is under the microscope. It requires very, very fine, precise micro movement. So it may seem like there's a little bit of movement here, but in reality, this is the eye's moving less than a millimeter. And so here we have threaded it 360 degrees, and we've identified and captured the leading end of the catheter distally, and we're going to pull it through and unroof that drain 360 degrees, which we're doing right now. You can still see that blinking light there. And so that's really it. We're going to pull it out of the eye, and that's the procedure there. It just takes a few minutes. It takes longer to get set up than the actual procedure. And so these are all the minimally invasive glaucoma surgeries. It's been a really hot space, uh, in the last few years. But really, sometimes we need actual bigger surgery. We need incisional surgery to control pressure, and really, this is more of the bread and butter of what we do with, especially at UCI, where we're seeing really advanced cases of glaucoma. And so the trabeculectomy here on this is how you spell it. It's kind of a funny spelling, but it's been the workhorse for managing surgical glaucoma for decades. It's the gold standard for lowering eye pressure. It's an incisional surgery, like I mentioned, where we make a flap and the wall of your eye using your own tissue, a very small, very fine, delicate flap, and then we go under the flap and we make an opening in the wall of the eye to allow fluid to come out of the eye. So there's actually the conjunctiva or the skin of the eye. We've actually relaxed that back here. We make the incision, we close the flap, and then we close the conjunctiva. After that, what you get is you get this little dome here. It's almost like a tiny, tiny, tiny little blister, which just allows fluid to come out of the eye. And then at the slit lamp, this is what it looks like. So it's actually, you see, there's a little bit of elevation here, but you can't really see much here. There's no implant, and there's not a lot of inflammation. There's not a lot of redness to the eye. The trabeculectomy, it's a fantastic surgery, but you can see it is a little bit more invasive and than MIGS, and on the more kind of big gun side of the treatment algorithm. Another big gun procedure that we typically do, it's kind of our bread and butter. It's the glaucoma drainage devices, and also known as tube or a tube shunt. And you can see here, here's a couple of different types right here, but essentially what we're doing is we're bypassing your own drain that you're born with, and we're putting a new drain onto your eye. So we're replacing your plumbing system. But it's a plastic implant which is placed between the muscles of the eye. You can see here, it's a very low profile implant. Typically, you'll not be able to see it in place just by looking with the naked eye, but we can see it at our microscopes. But it sort of becomes a part of your eye, like something like maybe you have a hip replacement or you have a metal rod placed. It just kind of becomes a part of the body. And so this procedure, the glaucoma drainage device, as well as the trabeculectomy, again, both of these replace your outflow, and this is really, been the bread and butter of managing glaucoma, especially advanced glaucoma. But again, like I mentioned earlier, our goal is to actually maybe not get to this point, but to identify early, screen early, and then, manage with laser drops, maybe minimally invasive glaucoma surgery, which the MIGS, which we often combine with cataract surgery. And so that's really kind of took you through the full spectrum of the surgical options as well. But what we're talking about: drops, medications, surgery. What are some things you can do? What about lifestyle? So, actually, I just want to put a plug out for lifestyle because it's something that all of us can control. And so multiple studies have demonstrated that, we can actually influence our intraocular pressure. And so one thing would be dynamic exercises such as walking, jogging, running, cycling. It significantly reduces intraocular pressure, following the exercise in both healthy participants and glaucoma patients. And then foods high in dietary nitrates and antioxidants such as leafy green vegetables, cruciferous vegetables, root vegetables such as tomatoes, potatoes. They provide an exogenous source of nitric oxide, which could potentially help lower the intraocular pressure. And then thirdly, meditation, positive mindset, that's been shown to help and reduce intraocular pressure. And lastly, caffeine has been shown to elevate intraocular pressure, anywhere from 30 minutes after consumption to 90 minutes in the follow-up of healthy individuals. So just moderation is important. I drink coffee every day, but everything's okay in moderation. With that, I just want to thank y'all for your attention. I hope this has been helpful. I look forward to talking to y'all again.